So we heard a lot about different thoracic shunt lesions, and we all know it's the main topic of everyday interventional work, and closing these lesions for different approaches is much fun. This is the main area of our work, and leaving the focus to an infradiaphragmatic shunt lesions or vessels out of control, we are confronted with vascular malformations in different contexts. But the aim will be the same, maybe closure of pathologic shunt lesions. I decided to focus on three different topics. And the first one is an infradiaphragmatic shunt in the context of a congenital heart disease. It's a Scimitar syndrome. Here's the first description of it. It's from 1836 by George Cooper. It's a very rare but well-known entity, and we all know about the triad of dextrocardia, hypoplastic right lung, and drainage of the right pulmonary veins to the inferior vena cava. We are the so-called Scimitar vein. As this Scimitar connection can easily be found by echocardiography, the detailed anatomic course of the right pulmonary veins are not seen by echo, so we need different diagnostic procedures like MRI, which works very nice, like in this case. Or I've got a second one, I think. Yes. We need MRI as well to see the right ventricular volume load. Hopefully it works. It's not so good quality, I'm sorry. So RV enlargement is the main topic when we talk about operation in these children. CT, sometimes done, especially for pulmonary diagnostics. Here we see a reconstruction of the right pulmonary hyperplasia. So the hemodynamics in the so-called adult form, I will come to the other one later, is easily called a left to right shunt with right ventricular volume overload, like a relevant ASD. And with the difference that the main pulmonary blood flow is directed to the left pulmonary artery, as the right one is usually hypoplastic. An ASD is usually found as well. So the therapy is surgical. It's a rerouting of the right pulmonary veins through an atrial tunnel and an ASD to the left atrial, or by direct anastomosis to the posterior left atrial wall. This is usually postponed for optimal results. And when the timing is really different to clarify, but pulmonary hypertension and right volume overload with symptomatic cardiac failure is usually a good sign to go for operation. So there's a multi-center study of the European Congenital Heart Surgeons Association, which reveals 15% of right pulmonary vein stenosis post-operatively, what is not that much, regardless of the technique of the operation, but a 7% mortality in the operative correction. This mortality is usually found in the infants, and every of these patients have pulmonary arterial hypertension. So, and this is the main topic for me, because the pulmonary arterial hypertension leads us to the infants with early symptomatic Scimitar syndrome. And these are the Scimitar syndromes with pulmonary sequestration, as we see in this case. We call it the infantile form, and it's defined by early onset of severe symptoms. And the reason for the symptoms are usually large pulmonary sequestrations with large systemic arteries from the infradiaphragmatical area. Here we see a single feeding artery with a huge sequester and the blood flow through the sequester in the scimitar vein and the right atrium. So the hemodynamics is somehow different because we have a low resistant shunt from the systemic circulation to the scimitar vein, which leads to a reduction in effective systemic blood flow, and we have early pulmonary hypertension. So as I said, the result is early symptomatic cardiac failure, respiratory distress, pulmonary infections and hemorrhage, and pulmonary hypertension. So in literature, there's not so much, but a little bit, as well in our own experience, early recognition of these shunts and early interventional therapy as mandatory, and we can see recompensation in nearly 100% of these cases. Here you can see what we've done with this single feeding artery. This is a very easy single device closure, and this leads to stabilization of this infant. But occasionally we see much more complex lesions, especially when they are added by multiple aortopulmonary collaterals, as we see here in the thoracic part of the aorta. So this leads to complex embolization procedures, which are sometimes not done in one, but in 2 or 3 sessions, especially as residual shunts are growing with time and leading again to pulmonary overcirculation. Again, sometimes unusual shunts are found. Here we have one originating from the common hepatic artery after closure of the big feeding shunts. They can be closed as well by selective procedures, and some shunts are only found incidentally, maybe on an MRI like this case. This is a single feeding artery not seen by ultrasound because it's arised from the right renal artery. So this could be closed as well. Our data from the last 10 years reveals only 6 infantile scimitar syndromes. 3 of them are diagnosed in fetal screening, and 5 of them have shown early very severe symptoms and have been well stabilized with 1 to 3 procedures with 1 additional PDA closure. 3 children are still not operated, while 3, 6, or 9 years old. One of them has have massive right lung hypoplasia, so there's only minor shunt volume through the scimitar after closure of all aortic supplies, so we think there's no need for corrective surgery. To summarize this, pulmonary sequestration aggravates right ventricular volume overload, pulmonary hypertension, and cardiac failure by low resistance high flow shunt from the abdominal aorta to the right pulmonary veins. We usually see this in high symptomatic infants, and ultrasound is mostly but not always diagnostic. Closure is usually straightforward but sometimes complex, and there's a rate of recurrence. Overall, this concrete embolization treatments leads to a high rate of primary recovery, and the left adult form of the scimitar syndrome can be placed for surgery on a later time. One interesting report I found in the literature is this one, where an interventional complete treatment of the scimitar is possible to closure of the opening of the scimitar vein to the vena cava inferior because of the existence of a collateral to the left atrium. This is a dream for an interventionalist, but I think it's only very rare the case. Unlike these classic shunt lesions, portocaval shunts is the next topic of my talk. It's a very different story. Portocirculation is directed to the liver, and portovenous blood will be cleared by liver parenchyma from several nitrous substances like ammonia and others before entering in this in systemic circulation. So the problem of portocaval shunting is qualitative and not quantitative. So exactly, there's no volume effect to the circulation. So what is the problem with portocaval shunting is that these shunt of blood from a compartment which has not been connected or should not have been connected to the systemic circulation arrives at the pulmonary vasculature as well as the brain. And what we see is hepatopulmonary syndrome with cyanosis and pulmonary hypertension, and we fear adverse effects on brain development, brain function, up to the hepatoencephalopathic syndromes. Yes. We are faced with two entities. The first one is a persistent ductus venosus, and the second one are the Abernethy Malformations. Diagnosis is usually made by ultrasound, but in most cases it's a long time missed because they are not suspected and they are not searched for, and the experience with these malformations is really low. MRI is often disappointing, and if we have a diagnosis, retrograde angiography, especially during balloon occlusion, from different approaches, defines anatomy and treatment options very nice. To explain a little bit about the Abernethy malformation, I have this scheme here. So we see type 1 and type 2. In type 1, we don't have any interventional option because there is no connection of the portal vein to the intrahepatic portal veins. They are definitely absent, so transplant is the only treatment option. For us, it's really interesting to work with the type 2 Abernethy syndrome, where we have different connections. So we have been confronted with one patient with severe hepatopulmonary syndrome with the late diagnosis of persistent ductus venosus, and after treatment, which was possible, a balloon occlusion and device occlusion of this ductus venosus, the patient recovered. And we thought about this entity first. We developed a local concept for treatment of these patients before the age of 5 or when they are symptomatic, and would like to do angiographic determination of the anatomy and the portal, or the degree of the portal hypoplasia, and do a balloon occlusion whenever possible with pressure monitoring, and try to perform interventional closure of the shunt if the occlusion pressure remains low, maybe below 15 milligram of mercury, depending on the degree of portal hypoplasia and the anatomy, which is not always suitable for balloon occlusion and not suitable for interventional treatment. In these cases, we go for open laparotomy for banding of the shunt under pressure monitoring, which is done through a microcatheter, which we put inside, and go for a second look interventionally with, again, pressure monitoring, anatomy, demonstration of the anatomy of the portal vessels, and maybe interventional closure. So here you see one of these cases with persistent ductus venosus with a huge portal vein. Maybe I find the laser over here. This is a huge portal vein with very small intrahepatic pulmonary veins, and this is a ductus venosus. It's intubated coming from the jugular position because of the angle to the inferior vena cava. We do a balloon occlusion and inject contrast medium here, and you see very nice the very, very small intrahepatic portal veins. In this case, complete closure was possible. So there is a AVP2 inside with 10 millimeter diameter, and it occluded it perfectly. This is possible because the pressure rise is only very low. In the Abernethy malformations, we are usually confronted with side-to-side shunts with very, very short course and very broad shunts, like in this ultrasound vena cava inferior, vena porta extrahepatic. So again, here is an angiography of the enlarged vena porta with a big shunt to the vena cava over here, and the very small and tiny intrahepatic portal veins. So in this case, the pressure is really high after occlusion of the shunts, so we go for laparotomy for bending under continuous pressure recording. And after a follow-up on an outpatient department, we see him again 10 months after the bending of the portal shunt, and see a very nice development of the intrahepatic pulmonary portal veins. And again, we do a balloon occlusion and see a rise up to 10 millimeter mercury, and decided to close it, in this case with a duct occluder, which works very nice and is a regular follow-up by ultrasound, as we see here. So there's the vena cava, the duct occluder, and the portal vein, which is flowing very nice. Important in the follow-up is a Doppler flow measurement in the flow in vena lienalis, portal veins, to be sure that there is no portal hypertension, which is the main concern in closing these shunts. In the late follow-up, we have to screen for hepatic tumors because these are sometimes found in these Abernethy malformations. The colleagues from Zurich, Walter Knirsch and Oliver Kretschmer and others show a very nice case which they use a diabolo stent to reduce the blood flow from an Abernethy malformation or persistent ductus venosus to the vena cava to get time in a very, very huge vessel. So we have that time 6 patients with these problems. The first one, 2 brothers, interestingly. The first one was our first patient with severe hepatopulmonary syndrome for over half a year, which we need this time to get the diagnosis because nobody knows. He was able to be treated with an ASD occluder with 10 millimeter, and that works very nice. The hepatopulmonary syndrome has been gone after 24 hours and not come back. There's no problem with portal hypertension, and he's fine. The next one was his brother. He was treated on an elective basis without symptomatic, without any huge pressure rise in the occlusion. The next ones were different. These are Abernethy cases with portal hypoplasia, and we go to 3 operations on them, and 2 of them has been totally closed. The first one by thrombosis after the operation with no problems in the follow-up, and the last one because the pressure under bending stays below 20 millimeter of mercury, and he was closed totally. And this one is the only one we followed our concept of a secondary closure after 10 months, which works very, very nice. All 5 children are very well, and there's no sign of portal hypertension. The 6th case is just waiting for a procedure to be done. The last topic of these vessels out of control are pathologic vascular beds in the context of oncologic disease, which we are confronted in our hospital, which sometimes lead to high output failure of the heart and pulmonary hypertension. And so we have, or I have 2 cases to show you, where we are asked to stabilize these children. This one is a newborn with a prenatal known giant teratoma with an extra and intra-abdominal part with cardiac failure and pulmonary hypertension, 3 kilograms of weight. And during MRI, which has been done preoperatively, we found a major feeding vessel to the abdominal part of the teratoma, and we are asked by our pediatric surgery department to help in closure preoperatively to get a better cardiorespiratory status preoperatively and to diminish bleeding during operation. So in this case, we go from an axillary approach and be able to get to the feeding vessel and have to be sure not to close the iliac artery over here, but this was very easy done. So we get, after coil occlusion of this main feeding artery of this giant teratoma, we achieved a good hemodynamic stabilization for operation next day. In the literature, I found one report, some colleagues who have done it for several times and think that it's a safe and effective alternative to an open laparoscopic tumor vessel occlusion, which could have been done otherwise. The last case of the day is a 3-month-old infant. We see in our emergency department and intensive care unit with unexplained cardiac failure and cardiogenic shock with acidosis and uncontrolled hypertension, renal failure. And the reason for that was found in a giant nephrogenic tumor with very high renin. And in this case, again, we found a major feeding vessel as seen in this DSA here with a huge amount of shunt to the inferior vena cava through this large tumor, which is over here. And here is the main tumor feeding vessel, and below there's the right renal artery. So we decided to perform a closure interventionally of this feeding vessel as well. And this was very nice in the result of easy controlling of hypertension and great hemodynamic stabilization of the baby, which has then an LVEF of 40% and was able for complete resection of this nephrogenic tumor and is very well so far. So I think it's very helpful if we can extend our interventional skills to atypical areas below the diaphragma as well, in the management of different shunt lesions, and interdisciplinary approach is critical in diagnosis, indication, and follow-up of these patients. Thank you so much for your attention.